is that all about? Why is that a good thing?
Dexcom is, let me explain this, is a continuous glucose monitor. Normally when people are checking blood sugar, they prick their fingers with a lancet. It hurts them. Check it 3 to 4 times a day.
Sure.
Whereas Dexcom is a small plastic tube which is put inside the belly or on the forearm.
Okay.
It stays there for 10 days. There are many other types of machines, but I'm familiar with Dexcom.
Sure.
The one advantage with the Dexcom or a continuous glucose monitor is you can see the blood sugars. I use it in type 2 diabetics and also on insurance approves for people who are on insulin. But some insurances are considering it as if you proactively help a patient. I recently had a patient with a hemoglobin A1C of 10.6. His insurance had called and said, we will approve Dexcom. I put him on Dexcom. He called me a couple of times and we educated him about the diet. He changed it and now he lost weight. His blood sugar is always at 90, 95. Yeah. So anytime when he eats or drinks, he understands how much it is affecting his blood sugar.
Right. Yeah, it's like real-time feedback.
Real-time feedback.
Yeah, oh, that's interesting. Okay, good.
The average drop of blood sugar can be 50 to 100 points, depend upon person. So with an exercise, you can have a good blood sugar control. And in any diabetic, without exercise, diet, and ideal weight management, giving medications is not sufficient. These three plus insulin in type 1 and pills in type 2 becomes important.
Okay, so it's really a global lifestyle approach to diabetes. I guess that's why it can be tough to live with and tough to treat.
Tough to change.
Right? Yeah. Okay, so then so that was kind of finishing off on type 1. So let's go back now. Type 2. What's the management approach to that?
In type 2 diabetes, once again, it's predominantly because the body is producing insulin, but because of insulin resistance, as people gain weight or if they have abdominal obesity, as in Indians where there is a lot of insulin resistance, the insulin is not working. Once again, helping them to understand the diet. Anytime when I start treating a diabetes, I tell them our goal is to get your hemoglobin A1C to 6.5. So on an average, diet brings it down by 1 point, exercise by 1 point, and every other pill we add will drop it by 0.8 to 1. And if you want, technically even before the pills, if you make the changes, you can drop it by 2 points. The one important thing I tell absolute no for all diabetics is no sugary drinks, no fruit juices, and that's important. And it's a common habit. A lot of people add sugar in coffee and tea. I say absolutely no. Even jaggery and honey, absolutely no, because it's very so that's very important, I would have. And then I start going for there are many classes of drugs in diabetes for type 2 diabetes. Some are injectables and some are pills. I generally start with which is most beneficial and most safest and long-term data is available is metformin. I like metformin. And if their kidney function is normal, the beauty with metformin is there's the longest data, not many side effects. But the most important thing with the metformin is it should always be started very slow. Don't go up too fast. If you go up, patients have diarrhea. So what I tell my patients who are taking metformin is start 1 tablet and after 2 weeks go to 2 tablets. After 3 weeks, 3 and 4 weeks, 4 tablets. So gradually build it up. The one advantage with metformin I like is it does not cause low blood sugars. Even if you don't eat meals, you don't get hypoglycemia. And I used to have a teacher who's a diabetic. He used to get mad when we had a patient with hypoglycemia. He used to ask us, have you ever had hypoglycemia? Do you know how it feels? So educate hypoglycemia. We educate our patients hypoglycemia as a part of diabetic education when they are going through the clinic itself. We'll talk to them about it.
Because just from talking to patients in clinic, all it takes is that one episode of low blood sugar and then you cannot get them back on board with their treatment because it's so miserable. And so yeah, you can, and so you're right. That is so important to be sure to avoid those because you can ruin everything moving forward. That's very true. So I'm glad you brought that up. Okay, so a bunch of different classes of medicines for type 2. So it sounds like you kind of have to play around with the medicines to find a good regimen for somebody that they can tolerate that works.
Yeah.
Does that sound about right?
Yeah, there are many classes of drugs.
Yeah.
I can go over the details, but it's more. But one class of drug I'm staying away more and more is sulfonylureas or glipizide and glipizide-like drugs.
Yeah.
These are very inexpensive drugs, but they're available for a long period of time.
Yeah.
But there is no data that helps in protecting the heart or kidneys or anything.
Yeah.
The one downside with this is it causes hypoglycemia.
Right.
It's well known in elderly patients.
Yeah.
And I hate hypoglycemias in
Right.
elderly patients
Yeah.
because
Yeah.
they get. I have a couple of patients who were on sulfonylurea. I acquired these patients from another doctor.
Yeah.
First time I told them, hey, your A1C is good, but your weight is also good. I think we should stop the sulfonylurea.
Yeah.
They didn't like it because they trusted that medication.
Sure.
Luckily, we have some samples of continuous glucose monitor, Dexcom, which I'm more familiar with.
Yeah.
And I said, we have a sample of it. If you don't need to prick your sugars, just put the Dexcom and see what happens.
Yeah.
In the middle of the night, he had a blood sugar of 40.
Wow.
He did not even know that.
Wow.
And so next day morning, he said, doctor, thank you for calling me and telling. One of the reasons in a diabetic patients is I will look at many aspects. It's not just A1C.
Yeah.
What is the long-term benefit of the medication?
Sure.
How is it protecting the heart? How
Right.
is it protecting the kidneys? What are the other comorbid problems?
Yeah.
Glipizide is inexpensive and sulfonylurea is inexpensive, but
Yeah.
hypoglycemias eventually will cause memory problems at 70 and 80.
Yeah.
That is not good for the patient.
Right. Yeah. Okay, so with type 2, it seems like that comes on later in life, right?
That's good.
Who's at risk for developing type 2 diabetes?
That's a good point. I'm glad you mentioned that it comes on later in life.
Yeah.
But nowadays in US, we are seeing both. Even kids who are obese, they had type 2 diabetes.
Okay.
And
Sure.
I'm glad you mentioned that.
Yeah, I'm an adult physician, so I don't always see those
So
cases,
actually, I have
I'm
seen,
glad you said that.
there's a study published in Journal of Endocrinology.
Yeah.
Indian kids, Indians most of the times they're rice eating.
Sure.
And if they're obese, their risk of developing diabetes is high.
Yeah.
And African Americans, and especially I have seen an African American. His dad is a diabetic. He brought his son also. Can you check me? His son is a very smart young guy. He wants to get onto a very dynamic guy. He came and said to me, I'm doing very well, but his hemoglobin A1C is 5.8.
Huh.
So he started developing
Yeah.
pre-diabetes now itself. So in another 5 to 10 years, he's at risk of diabetes.
Sure.
So
Yeah.
it's important to understand if you don't make changes. Now, one of the worst culprit for diabetes is sugary drinks.
Yeah.
And the more you drink sugary drinks, and the more is the risk of diabetes because you require more insulin, you put more burden on the insulin. These are empty calories. You don't even realize that you're consuming calories,
Right.
and gradually the insulin resistance goes up and
Yeah.
then becomes a problem.
Yeah. Okay. And then how do you monitor like type 2 diabetes, the progression of it?
Yeah. So when we see, before I go on monitor of type 2 diabetes, one aspect which I have seen in many patients coming to my clinic is they come to my clinic, but they don't take their shoes. And in a diabetic examination, without checking the feet, it's not a complete examination. A lot of people don't even realize it. The one reason I want to emphasize the feet examination specifically is, one, when we examine the feet, we check for the pulses to see how the blood supply to the feet is. That
Right.
gives a good idea. If they have a circulation problem, the risk of heart problem is very high.
Sure.
We also check for the sensation. Because diabetes is a silent disease, by the time we diagnose diabetes, they might have had a damage to the sensation and nerves are damaged. They can get ulcers in the feet.
Yeah.
And we also educate about how to take care of the feet. This is a common thing. A lot of people go to nail shops and they get a clean cut nails.
Right.
But that's not the best way to do it. If you cut your nails very perfect, you tend to get ingrowing nails, so
Yeah.
that is a problem.
Yeah.
So I generally educate my patients about foot care, and that's a very important part. Once they have a foot problem, they won't do exercise.
Right.
They will postpone it. They have a reason, and that is a genuine reason.
Sure.
So we start with that. Now, coming back to monitoring, first we established once they're diagnosed, I tell if it is in the first 2 years of diagnosis, it's a golden period. If you do manage very well, you are preventing many of the complications.
Yeah.
The way I tell my patients is hemoglobin A1C once in 3 months.
Yeah.
I strongly recommend it.
Okay.
Urine microalbumin, blood pressure, making sure cholesterol is in a good range.
Yeah.
And
Okay.
these are the things which I look for.
Okay.
And also baseline kidney function test, we do that all the time.
Okay. Good. And then, we talked about oral medicines. Do type 2 diabetics ever require insulin?
Yes, that's a good question.
Yeah.
I mean, it's partly because insulin is very useful in type 2 diabetes management also. One thing I want to emphasize, if you require insulin, doesn't mean they require lifelong insulin in type 2 diabetes.
Okay. All right.
For type 2
For
diabetes.
type 2. Okay.
But in type 1, you require lifelong insulin.
Yeah.
So in type 2 diabetes, I emphasize that sometimes I used it. Recently, I had a patient. She went to Mexico and she came back. She doesn't know she's a diabetic. And she came to our office. The blood sugar was 450.
Wow.
And we gave insulin. Sometimes we manage as an outpatient also when
Yeah.
the blood sugar. It did not come down. We waited for 2 hours, plenty of fluids, didn't come down.
Wow.
We sent her to the hospital, and in the hospital we got in the meantime we got a phone call from the lab. Her blood sugar was 2,000.
Holy smokes.
Yeah.
Wow.
Her blood sugar was 2,000, creatinine was 2.4, sodium was 1. This is the highest blood sugar I've seen.
never heard of that.
Yeah.
Yeah. Wow.
It's funny, normally the red cell volume is 90.
Yeah.
And in her red cell volume went up to 120. I was never
Wow.
seen that.
Wow.
So she was in the ICU for 2 days.
Wow.
She was on insulin drip and other things.
Yeah.
And she was discharged home, and she came and saw we weaned off the insulin. Now she's only on metformin 500 twice a day.
Yeah.
So
Wow.
in type 2 diabetes, once they understand the diet,
Yeah.
one of the reason I feel we are successful is some of the insurances cover something called chronic care,
Uh-huh.
where people like diabetes, they can call the doctor anytime
Yeah.
for up to 30 minutes.
Yeah.
First time when they're diagnosed, we take it very seriously and help the patient understand it.
Yeah.
We don't say come back in 3 months.
Sure.
We ask them to call us based on the blood sugar.
Right.
So once they get the confidence and trust, and they learn, the most important thing is there's a learning curve for the patients.
Yeah.
When we help them to learn when they're very sick,
Right.
they'll always make the right changes. This
Right.
girl, she's only on metformin 500 twice
Yeah,
a day.
that's amazing with the
Yeah.
blood sugar of 2,000.
Yeah, from
to be-
2000, and
Yeah,
this is
that's
not
impressive.
the one. Yeah, she
Yeah.
did very well.
Yeah. So real quick, because you mentioned something called a Dexcom.
Yes.
Let's talk a little bit about continuous glucose monitoring, because this is getting a lot of write-ups and stuff, and I think there are some electronics companies that are trying to incorporate it in their wristwatches and stuff. So what is that all about? Why is that a good thing?
Dexcom is, let me explain this, is a continuous glucose monitor. Normally when people are checking blood sugar, they prick their fingers with
Yeah.
a lancet. It hurts them. Check it 3 to 4 times a day.
Sure.
Whereas Dexcom is a small plastic tube which is put inside the belly or on the forearm.
Okay.
It stays there for 10 days. There are many other types of machines, but I'm familiar with Dexcom.
Sure.
The one advantage with the Dexcom or a continuous glucose monitor is you can see the blood sugars. I use it in type 2 diabetics and also on insurance approves for people who are on insulin. But some insurances are considering it as if you proactively help a patient. I recently had a patient with hemoglobin A1C of 10.6. His insurance had called and said, we will approve Dexcom. I put him on Dexcom. He called me a couple of times and we educated him about the diet. He changed it and now he lost weight. His blood sugar is always at 90, 95.
Yeah.
So anytime when he eats or drinks, he understands how much it is affecting his blood sugar.
Right. Yeah, it's like real-time feedback.
Real-time feedback.
Yeah, oh, that's interesting. Okay, good. So we're actually coming to the end of the show. We got about a minute left. And so remember, folks, check out Facebook, Instagram, Twitter, and our website, doctalklive.com, to find more information about next week. And like us on all those different platforms. Anything real quick you want to say to our listeners, Dr. Katari?
Yes, in type 2 diabetes, if they require insulin, that doesn't mean they'll require it forever.
Good.
But there are many options.
Yeah.
But definitely diet, exercise, and weight loss are the most important things. But there are good medications like dapagliflozin and empagliflozin,
Sure.
which are helpful for kidneys
Yeah.
and heart, which I'm using it more often.
Excellent. All right. Thanks again for coming on, Dr.
Thank you.
Katari. It's been great seeing you again and having you on the show. This is Dr. Cespedes signing off. Stay healthy, America.
Thank you for having me.